Hello, I'm Michael Hainsworth. Millions of Canadians don't have a family doctor. The lack of access to a family physician is a critical issue. But why? Among the factors, an aging doctor demographic, outdated payment models, and the fact we have doctors from other countries driving taxi cabs in Canada. And the solution isn't just throwing more physicians at the problem. This is Tingting Zhang, a junior policy analyst at the CDHI Institute. In Commentary 660 titled The Doctor Dilemma, Improving Primary Care Access in Canada, her research revealed 5 strategies for addressing the primary care access gap. Expand the number of trained physicians, reduce the paperwork, offer alternative payment models, expand the scope of practice, and expand team-based models of care. Joining her for this discussion is Rosalie Wyonch, a senior policy analyst at the Institute. Thank you both for joining us.
Happy to be here. Thank you for having me.
Tingting, how many Canadians are without a family doctor, and where is it the hardest to find a family physician?
In 2022, there was 14% of Canadians who did not have a primary care provider. I think like Prince Edward Island, Quebec, or Newfoundland are the provinces that among the most difficult to find a primary care provider.
People in rural locations all over Canada, even if there are enough doctors, they might not be taking new patients. So I think really when Canadians move, that's when they have the biggest struggle, or when your existing doctor retires. Really, it's trying to find a new doctor is really a challenge across the country, but it can be more of a challenge in rural areas or particular provinces like Tingting mentioned.
It's remarkable to me that of the 39 million Canadians or so, about 14% are having difficulty because they don't have a family physician. And that comes with a cost in the form of fees?
Yes. If they don't have a primary care provider, when they get sick, the default option is go to emergency department. And then to treat a minor disease at emergency department costs like $165 per visit. But then for family care provider, visit is only $65 per visit. So that's like 3 times more.
When we look at these sort of those additional costs across the system, it does add up to a significant cost for government, but potentially more importantly, when people are going to the emergency room for routine care, there is a limited capacity there. And we need to make sure that when there is an emergency, that there is capacity in the ERs. So really, this is a bit of a domino effect where if you don't have access to primary care, it can add costs for government, but it can also put other Canadians at risk because it overloads our hospital and emergency care system.
So then let's tackle each of these 5 key components one by one. Tingting, what's the primary hurdle as you see it to filling positions at all?
The workforce of family physicians, much like the rest of the population, is aging. There are just not enough new medical graduates to replace these retiring physicians, and also to meet the needs of our growing demands of patients.
Rosalie, you and I have been talking about this problem for years.
Yeah, we have. And I would say in addition to really just simply not having the number of graduating physicians or people joining the labor force matching up with population growth and those leaving, we also see that physicians are spending less time on direct patient care and more time on things like administrative work, potentially other professional obligations. And so I think there's some potential to actually just get more access to primary care by freeing up some of the time that existing doctors are spending doing other things. So if we can maybe minimize some of their administrative work or speed up some of these processes, then they can actually see more patients in less time. And that could actually really improve our access, I would say potentially even more so than growing the total number of physicians.
Well, help me understand that a little more, Rosalie, because the administrative burden just sounds like all you need is an assistant or another secretary at the front desk. And paperwork, isn't that sort of part of the checks and balances of any given system?
It certainly is. And I mean, in medicine, if you don't chart it, it didn't happen. And so obviously a certain amount of their administrative work is necessary. Could be, you mentioned assistants. So it could be people that are specialized in medical documentation and can speed up some of that administrative work. One of the issues, though, is that for a family doctor to have someone like that, they actually need to pay for them out of their own salaries. What we see as the sort of top line number that doctors would get paid doesn't include the fact that they have to pay for their own office space, their own equipment, and they also have to pay support staff. And so for a doctor, if there's a chance that the amount of time that they would save isn't equivalent to the salary of a really good assistant, then it might not happen. I think there's also things that we can do on the government side or really just throughout the healthcare industry that could remove, shall we say, the unnecessary administrative work, while we're also looking for solutions to make the necessary work more efficient. And that would be simple things, low-hanging fruit, like every insurance company has a different form, and that form can only be signed by your physician. Submitting data for health quality purposes. You might have it in your charts, but it needs to be collected by hand. And so there's just a lot of, shall we say, unseen work that's related to forms and data that could potentially be streamlined and would be a win-win because doctors would save time and it would likely reduce costs as well on the government and insurance side. So really anywhere where we can make these processes and systems more streamlined would be of benefit to everyone.
You know, I know that maybe artificial intelligence isn't exactly the most popular topic recently, but Tingting, is there a technological solution to this part of the problem?
Ontario actually recently introduced a pilot project try to use AI to automate the documentation of patient conversation with their content. So that will help, primary care provider to save some time to make notes. So those documentation can automatically transfer to be electronic medical records, which can save the unnecessary administrative work that Rosalie just mentioned.
On the topic of alternative payment models, I found myself at an eye doctor recently with a brand new state-of-the-art facility and a sign that warned of a wait as great as 3 hours past my scheduled appointment. That felt like patient stuffing, and the luxury environment appeared to sort of back that up. The Institute's already raised the alarm over fee-for-service models that encourage doctors to over-treat patients. But what's the alternative?
The alternative can be capitation. Primary care providers get paid for caring for one patient throughout the year. And it can also be bundle payments, so mixed with fee-for-service and capitation or other incentives. So alternatives can be many, but the problem is how to hold physicians accountable for the services they delivered, and whether the payment reform actually improve patient access, especially for the older patients who need more complex care.
And sort of once you get thinking about how you might pay people, you can go a layer deeper and think, how do you structure the business that is a primary care office? Traditionally, it's sort of the physician that works long hours. Maybe they have a nurse that doubles as an admin, but it's really sort of a small team that is essentially the physician is the provider and then some support services. But many countries, and we've taken some steps towards this in Canada as well, have started to move towards team-based care, where the things that you need to see a doctor for, you'll see a doctor, but for a lot of care, it can be provided by nurse practitioners, potentially medical technologists that or assistants that can, give you vaccinations, with the added input of pharmacists. Really, once you get all of the different providers together and working together, then everyone can focus on sort of their area of expertise, and we can deliver primary care much more efficiently if we stop thinking about it as a service that can only be delivered by physicians. And that's something that some provinces are moving towards, but we need to think about it in line with how are people compensated, what does that mean for how you structure the business, so that we can ensure that we don't just do team-based care in name, we actually reorient care delivery to be more efficient and give patients better access.
What do you say to those who are concerned that this is sort of a thin edge to the wedge towards a whole American-style healthcare system?
Well, maybe I can jump in there, because earlier this year, I think we recorded a different podcast about public-private regulations in the landscape in Canada. And I would say that realistically, we have an almost entirely public physician system, but when 14% of people don't have access, the market will respond to that need. And so we do see things in, say, the gray areas of the laws and regulations, or where it's allowed. For example, in Ontario, nurse practitioner clinics can deliver primary care privately, and they exist, and I assume they have patients, or they wouldn't stay in business very long. So in a lot of ways, I see the rise of virtual care through insurance providers, or the creation of these nurse practitioner-led clinics as a private market response to fill the gap that the government is failing to provide for. While we can talk about what's ideal from a principled point of view, I think that if we're going to talk about equality of access, we need to actually be able to have access. And when we can't reach that bar, I think it's reasonable to consider the other alternatives, and the private market is successfully filling some of the existing primary care gaps in the public system. But we should absolutely sort of look at that and think about how we can regulate it or manage the private market in such a way that we can keep those principles of equality, universality, that they have in lots of European systems that are mixed public-private. There are other systems outside of the United States, and I don't think anyone is aiming for a U.S.-style system, almost including the U.S.
Tingting, Rosalie brought up an interesting point about team-based care. Let's talk about the role expanding the scope of nurse practitioners and pharmacists would play in freeing up doctors. What are doctors doing that NPs and the person behind that tall counter at my pharmacy could do?
Primary care providers, family physicians, they treat and care for the patients. They order the lab test, and they refer patients to specialists. And many of these tasks actually can be done by nurse practitioners. Over the past few years, the scope of practice for nurse practitioners have already expanded in many provinces. But then, as Rosalie mentioned, they are underutilized in our system. The payment model for nurse practitioners does not catch up with their scope of practice. So there's that gray area. For pharmacists, they're good at medications, so they can track the patient's medical history and to give them advice in terms of medications. They can also treat some minor ailments, actually. There's many provinces, including Ontario, BC, Nova Scotia, they have extended the scope of practice of pharmacists to treat the minor ailments, such as pink eye. So that can save some time for family physicians who can treat more complex disease for patients.
The idea behind it is really so that each professional can practice closer to the limit of their scope. It's not that family physicians shouldn't be doing some of these things. It's just that other people can, and might be better if those physicians could dedicate more of their time to managing the complex or ongoing issues that their patients might have, whereas the say routine things like antibiotics for pink eye or your routine vaccinations would be something that could be handled by other professionals within the team. And only when you're really sick or actually don't know what's going on would you then see your doctor. But a majority of the volume of what we go to family doctors for could potentially be handled by other professionals. It's really just the more complex, or when we need, shall we say, the diagnostic expertise or that additional context about someone's medical history and the development and trajectory of their chronic condition over time.
So let's do sort of a rapid fire reaction to which provinces need to do the most work on your 5 key recommendations. 1, increasing the supply of family physicians.
Well, I think Alberta and Quebec need to do more in this regard.
Reducing administrative burden.
New Brunswick, Newfoundland and Labrador, PEI and Quebec.
Implementing alternate compensation models.
PEI and Quebec.
And expanding the scope of practices.
Manitoba and Newfoundland and Labrador. I mean, Alberta also need to do so, but they already have full scope for their pharmacists, and they are extending their scope for nurse practitioners. So even though it is rad, but they already did a lot of improvement in the past few years.
And expanding team-based models of care.
Quebec.
Sounds like every province has something they need to be working on at this point in time.
Right. That's right. And even those who are doing well, who implementing the 5 strategies, doesn't mean they already achieved the goal. They still need to working towards the goal and also implement performance measurement and accountability mechanism to really measure the outcomes of each strategy and see whether the access gap in their provinces has been reduced or not.
Yeah, and I'd maybe say that it's when you look at the table, it becomes somewhat obvious that Quebec is the one that is, shall we say, not actively working towards implementing these 5 strategies compared to the other provinces. Some provinces are focusing on a particular area, and others are actually making progress a little bit more across the board. And one, we've been talking about a lot of depressing stuff, but I just wanted to highlight Nova Scotia as one that's been doing a lot. Really, I think there are some good news stories in the country, and those provinces that maybe are further ahead or have implemented these changes in the past, or are really just trying to go across the board and really focus on improving primary care, might have lessons for the other provinces, and also that we can learn from the results of what worked, what didn't, and potentially tweak how we implement these things as we move forward as well.
Thank you both so much for your time and insight today.
You're welcome.
Always happy to be here.
Tingting Zhang is a junior policy analyst at the CDHI Institute and author of The Doctor Dilemma, Improving Primary Care Access in Canada, available at cdhow.org. Rosalie Wyonch is a senior policy analyst at the Institute and a contributor to the commentary. I'm Michael Hainsworth. Thanks for joining us.
You've been listening to the CDHI Institute podcast with Michael Hainsworth. Subscribe on iTunes, Google Play, and Spotify. The CDHI Institute is an independent, not-for-profit research institute whose mission is to raise living standards by fostering economically sound public policies. The Institute is widely considered to be Canada's most influential think tank and a trusted source of essential policy intelligence, distinguished by nonpartisan, evidence-based research and subject to definitive expert review. Visit cdhow.org and follow us on Twitter and LinkedIn. Thank you.